So, good afternoon to all the participants. So, before going to the program, I just want to tell about the guidelines of Chat with Champion Buddies lecture series. Please dedicate this 45 minutes of committed time for each lecture session and sit in a quiet place and a public environment, external distractions and interruptions. Put your phone on silent mode and switch off the camera in Google Meet to avoid distraction. Discuss with your other colleagues and update yourself in case you are missed out on a session. Take notes during the session. Please email us all the queries. It will be answered before the next session. So no in between discussion session will take place. Kindly fill the feedback form at the end of the session, which will be posted in the chat box, and claim for the certificate for attendance. So hope you all know about what today's topic is. We all know that children are most prone to the trauma or accidents in home or schools. So in pediatric industry, the most common or laxative injuries are very rare, like avulsions or complete exarticulation of the teeth. So we have laxative injuries like extrusion or lateral luxation or intrusion. So today's speaker will be talking on lateral luxations of primary and permanent teeth, which has been successfully managed and with along with the recent guidelines and cases reported and management various different management options and prognosis and follow-ups. So today's speaker has followed up of a lateral luxation of two cases of lateral luxation in primary and permanent teeth for 6 years. Sorry, just admit the people. So I'm very happy to welcome today's speaker, uh, Dr. Anusha Mohan, and with a short CV of her, and then I'll just let her know so she can start the presentation. So Dr. Anisha Mohan has completed masters with the gold medal of best going outgoing student from our university, Srihar, and also she has done her undergraduation from Ramchandra University. She's a fellow of in the Hospital of Sick Kids Children, that is Sick Kids from Canada, from 2019 to 20. And she has presented many papers and posters in many conferences. She attended quiz, and she's also got many best paper and poster awards. And she also done publications in Carey's Research Journal and International Journal of Pediatric Dentistry, and with and also systematic three systematic reviews, and also few protocols has been submitted. And she also got academic awards for the B.R. Subramanian Gold Medal for Best Outgoing Postgraduate Student, and also Byton Awards for the Best Postgraduate Student of the Year. And she was selected for the FAMDent Excellence in Dentistry Award in the category of Highly Recommended Student of the Year. And she's working as a consultant in different hospitals. Also, she participated in many international conferences and presented posters and papers. And she also completed a few online courses from Coursera from different university like John Hopkins University or Georgia University. So with this, she's also my UG friend and also batchmate from UG days. Friendship is continuing, and I'm very happy to welcome to our lecture series of Chat with Champion British, Dr. Anisha. So over to you. You can start the presentation.
Thank you, Vignesh. I hope you can hear me.
Yes, Anisha.
So I'm going to share my screen
Yeah.
now.
After you start presenting, I'll just unmute. If any issues is there, you can just talk and I'll unmute and speak.
Sure. So are you able to see my screen?
Yes, yes. You can click the hide option and yeah, it's in slideshow.
Okay.
Yeah. So I'm unmuting myself. So if any issues, I'll just unmute and speak.
Okay. Thank you, Vignesh. Good afternoon to everyone. I'm very happy that you are all able to take time to join me today. You're all either in the postprandial phase feeling sleepy, or you're very hungry and wanting to eat something. But don't worry, my lecture will be really short, and I'm going to show you two interesting cases. So hopefully you will be able to forget your sleep because of the interesting cases. So moving on to my topic today, lateral luxation injuries in young patients with a 6 years follow-up in primary and permanent teeth. So dental trauma is the most common cause for emergency in children, next to tooth pain due to dental caries. Obviously, dental caries and related tooth pain comes first, and second is dental trauma. But however, it's more common than what you all actually think. So luxation injuries, especially in primary teeth, almost constitute to 21 to 81% of all the traumatic dental injuries. So this is a lot in number. So luxation injuries, according to the degree of displacement, can be classified as either concussion, subluxation, lateral luxation, extrusive luxation, intrusive luxation, and avulsion. If we go into each one of it, this lecture is not going to be enough. So today I'm going to just concentrate on lateral luxation. So what is lateral luxation? It is defined as the displacement of the tooth in any direction other than axially. So usually it is associated with a fracture or compression of the alveolar socket wall or the facial cortical bone fracture. So these are two pictures. I hope you are able to see my pointer. So I have purposely taken these two pictures from the guidelines itself because it's given very small in the guideline and sometimes we miss it. So if we just look at this picture, we can understand lateral luxation more easily. So the first two pictures that are up and down shows the primary tooth lateral luxation, and the separate picture in the right shows the permanent lateral luxation. So if you look at the top picture, you can see that the tooth is displaced out of its socket and the root tip is caught between the fractured labial cortical bone. So this is one kind of thing that can happen where the crown of the tooth is displaced palatally and the root of the tooth is displaced labially. So if you move down to the lower picture, this is the opposite of what has happened on top. So here the crown of the tooth is displaced labially and the root of the tooth is displaced palatally. So in both these cases, there is fracture. In the top picture, there's fracture of the cortical bone, but in the lower one, there is compression of the palatal bone and the labial bone is fractured. So in permanent picture, this picture is very similar to what has happened in the top picture here, except for the fact that this is a permanent tooth and there is no developing tooth bud inside. But in primary dentition, always we will have to consider the developing tooth bud which is inside. So the damage to the tooth bud can happen if the root is going to be pushed palatally. It can damage the developing tooth bud. So this is how serious this lateral luxation injury can be. So moving on to my cases, first case is Master Sanu. He's a 9-year-old male who reported with a chief complaint of mobile tooth in the upper front tooth region with pain and bleeding following trauma. So he fell and hit on the wooden bed at his house while fighting with his elder sibling. There was no loss of consciousness or bleeding from the nose or ear at the time of trauma, and there were no previous history of trauma to the same tooth. He was brought to our clinic 2 hours after the incident had taken place, and this was the child's first dental visit. So this was how he initially presented to us. When we did the intraoral examination, we could find that the teeth 2-1 and 2-2 were displaced from the socket. And if you observe the incisal edge of 1-1 and 2-1, you can appreciate that the tooth 2-1 has moved out of the socket little bit, and also it's moved palatally. So this case was seen at the emergency department of our college, that is 6 years ago when I was a postgraduate student. And at that time, the emergency clinic used to operate after the routine clinics were closed. So due to that, we were not able to take a radiograph. But currently, even our emergency department has like portable radiographic machine and all that. So at that day when we saw this patient, we missed to take a preoperative radiograph. However, a clinical diagnosis of lateral luxation in 2-1 and 2-2 was given. And according to the IADT guidelines at that time, which was the 2012 guidelines, we decided to reposition the tooth digitally and put a flexible splint for 4 weeks. So according to the recent guidelines, 2020, which we all should be following now, the same treatment plan is advocated for a lateral luxated permanent tooth. However, the recent guidelines has added a lot of information on the different radiographic techniques that needs to be taken. And also, they have given the method more clearly regarding how we should disengage the tooth from the bony prominence and then put it back into the socket. And Also, information regarding how we should monitor the pulp condition of the tooth using periodic pulp sensitivity tests have also been incorporated. Also, the post-operative instructions, everything is incorporated into the recent guidelines. So it's more elaborate and more useful, like everything in one place. So moving on to the repositioning technique, this is very, very important, especially in lateral luxation. So this text box, I have literally cut out from the IADP recent guidelines. So if you read this text along with these two images, which are given in the Andresen textbook, it will be more easier for you to understand. So what has happened here is, like I already explained previously, in lateral luxation, the tooth is moved out of the socket and the tooth root tip is stuck between the fractured alveolar bone fragments. So what we have to do while repositioning the tooth is, imagine you're repositioning the tooth and this is your thumb finger and your index finger. So just palpate the gingiva with your index finger to feel the apex of the tooth here, and use one of the fingers, that is your index finger, to push the tooth little bit downward, and then use the other finger, which is your thumb, to put the teeth back inwards. So literally you push the tooth little downward and then back into the socket to its original position. This is very important because if you just, without doing a downward force, if you just try pushing the tooth back into the socket, this bony prominence over here is going to interfere and the tooth is not going to go back into its original place. Or even worse, this fragment can even break, causing even more complications. So this method, palpating the gingiva, finding the apex, pushing it down, and then pushing it back into the socket, is the right way of repositioning the tooth. So this is after repositioning, you can appreciate that the tooth is back into the socket and also the fractured alveolar bone comes back to its original position. This way, even the alveolar bone heals quickly. So post-treatment, for our case, you can see that splinting is being done and the repositioning, after repositioning, splinting is being done. So a flexible splint is used and composite resin is being used to stabilize the splint. So after repositioning, you can appreciate that the incisal edge of both the teeth match, and then the gingival arch is also maintained. So this is the radiograph which was taken the very next day after we called the patient the very next day to get a radiograph, because the previous day we had not taken a radiograph. So we ensured that there were no root fracture or anything. And this X-ray shows that there is no apical gap, which shows that the tooth is back into its original position. And even the pedial space, everything looks normal in the radiograph. So radiographic follow-up at 6 months and at 12 months. Now you can appreciate that the tooth was regularly followed up, and in radiograph previously the tooth was not completely, the apex of the tooth was not completely closed. However, at 12 months you can appreciate that the cementum thickening around the apical area and the roots are completely closed now in both 2-1 and 2-2. So this means that the tooth did not lose its vitality and it has continued its apical growth, and everything is being favorable so far. So this is the clinical follow-up at 6 months, 12 months, 24 months, and this is at 6 years. This picture was taken just 2 weeks ago. So I had a visual consult with the patient and I asked them to send this picture. So this picture was sent by the patient through WhatsApp. Probably that's where the clarity is not that great, but I guess the child is now 15 years old and he was able to do a good job with the picture. So you can appreciate that the tooth has not lost its color. There's no change in color, and everything else looks normal, and the child is not having any pain or sensitivity. Up until 24 months, when we saw him in clinic, we were doing regular pulp vitality testing, and the teeth were vital. And even now, there are no signs of any tooth mobility or like any discoloration. So, which means the tooth is staying pretty well. And also, the child has developed the complete occlusion. He's now 15 and he's got all the molars, second molars, everything in place. The only thing is, because he's not been seeing a dentist for the past 2 years in the pandemic, he's having a lot of plaque deposits, which I have given him instructions, and hopefully he maintains that. Otherwise, everything else looks good. So this was the follow-up from where we started and where it is. So when we saw him first, the child was 9 years old, and now he is 15 years old. And you can see the 2-1 and 2-2, how it's been saved. So moving on to our second case, which is Master Shrikar. It's a 3-year-old male who reported with a chief complaint of mobile tooth in the upper front tooth region with pain and bleeding following trauma. So he had a fall on the ground while playing in school. There was no loss of consciousness or bleeding from nose or ears, and no previous history of trauma. He was brought to our clinic 5 hours after the incident had taken place. He had a past history of wheezing for 2 years, but he was not on any medications unless it was symptomatic. So this means that he was not taking any steroid nasal spray. So this was the child's first dental visit. So this was how he presented to us initially. On intraoral examination, this child also had seen in the emergency department, but however, he had come little bit earlier, so we were able to open our department and take a radiograph at that time. So this intraoral examination showed that tooth 6.1 and 6.2 were completely almost out of the socket, just hanging in there with a lot of blood clots there. And the teeth had grade 3 mobility. Both the teeth had grade 3 mobility. And it was also interfering the occlusion because the child was not able to close the mouth fully. So the preoperative radiograph tells you how much the tooth has moved out of the socket. Both 6.1 and 6.2 was mildly out of the socket with pedial space widening. So her initial diagnosis of lateral luxation in 6.1 and 6.2 were given. So based on the IADT guidelines at that time, the 2012 guidelines, we decided, since there was severe occlusal interference, we decided to reposition the tooth by combined labial and palatal pressure after the use of local anesthesia. According to the recent guidelines, one major thing that you have to observe here is we did not have the recent guidelines at that time, and because of which we had actually missed something, which I will be telling you later. So we did not take two sets of radiographs. We just took one radiograph and decided to do the treatment. But however, according to the recent guidelines, they suggest two radiographs at two different angulations. But the treatment was the same. Gently reposition the tooth and give a splint for 4 weeks, which is flexible. And also follow-up needs to be done according to the IADT guidelines, which is if we reposition and put a splint, the review has to be done after 1 week, 4 weeks, 8 weeks, 6 months, and 1 year. So this was post-treatment, immediately after splinting and repositioning. You can appreciate that the tooth was put back to its original position. There was severe gingival damage because of the amount of luxation that had taken place. So the splint was done with a flexible wire and composite resin. So this is the radiograph after the splinting was done, and you can appreciate here that there was a root fracture at the apical third, which we had actually missed when we initially took a radiograph. So this was on the same day. So we were kind of confused after we saw the root fracture in the tooth. We were like, what should we do? Because the previous guidelines for root fracture suggest that we shouldn't be saving a primary tooth, rather we should be extracting it. So we were a little bit confused, but we had already done the repositioning and the splinting. So what we decided to do, we gave a final diagnosis of lateral luxation and root fracture in 6.1 and lateral luxation in 6.2. So some of you may be wondering why I'm giving two diagnoses for a single tooth. Always remember that in trauma, a single tooth can always have two diagnoses. For example, if there is enamel fracture in the tooth, that fracture can also have a luxation injury or anything else. So two diagnoses for single tooth is always possible in trauma. So since we were confused about the root fracture and the splinting that we had done, we did a little bit of literature search, and we found that there were no unfavorable outcome for the permanent teeth bud secondary to primary tooth fractures that were reported in the literature. And also a conservative approach, although it was controversial at that time, can be adopted, and attempts were made to save root fractured primary teeth, with extraction being the last choice. So after we did this literature search, even though the guidelines at that time did not suggest saving the tooth, we decided to carry on with what we had done. However, the recent IADT guidelines suggest that even for root fracture, there is an option of repositioning the coronal fragment and putting the fragment in its original position and giving a flexible splint for 4 weeks. So the literature from that time has been continuously changing, and it's been adopted well into the recent guidelines. Uh, Moving on to the treatment recap, we had repositioned the tooth and a flexible splint was done. Since the child was only 3 years old and was lacking cooperative ability, we had to use physical restraints at that time. But now you can always consider nitrous oxide sedation IV sedation or intranasal sedation. I have had the experience of working with intranasal sedation, that is intranasal midazolam or fentanyl, which can be given. Although the sedation does not put the child to complete sleep, it sedates the child enough. After the sedation, we can use a little bit of physical restraints and finish off the repositioning and splinting. However, these IV sedation and intranasal sedation, we need people who are trained to do that if we want to attempt doing it. Nitrous oxide, whoever is trained in nitrous can always use that. General anesthesia in emergency situation may not be possible because of the NPO rules. But however, if possible, we can even consider GA when it is available. Um, so another thing, we removed the splint at 2 weeks, at 4 weeks in this case. I would like to mention that since I had used physical restraints, the isolation was not that adequate, and hence when I saw the patient after 2 weeks, the splint had removed from two of the teeth. We checked the mobility of the tooth, but the teeth were actually mobile even at that point of time. So we decided to redo the splint at 2 weeks, and we left it again for 2 more weeks. And totally after 4 weeks, we rechecked the tooth, and the mobility had completely stabilized. And finally, we removed the splint by 4 weeks. So this is the reason I'm mentioning. You should always consider nitrous or IV sedation or intranasal sedation when possible, because you will be able to do a good job with the splinting. So regular clinical and radiographic follow-up were done for this patient. So if you look at the radiographic follow-up, at 3 months, you can still appreciate the root fracture and the apical fragment in place, but there were no other pathology seen in the radiograph. However, at 6 months, we observed that the apical fragment had completely resolved with no periapical lesion or any other signs of infection. Even at 12 months and 24 months, the tooth remained absolutely fine with no radiographic pathology. So moving on to the clinical follow-up, these were the clinical images at the follow-up visits at 3 months, 6 months, 12 months, and at 24 months. So you should also observe here, as pediatric dentist, the child also developed early childhood caries when he was under our observation. So because he was regularly coming to us, we were giving him fluoride and all that until the time he became cooperative to sit for permanent strip crowns in the lateral incisors. So at 24 months after trauma, we were able to place strip crowns for him and do the composite restorations, and some posterior fillings were also done for him. By that time, he was very cooperative for treatment in the chair. So in between, we were giving him fluoride, and we were also doing some temporary restorations just to save his teeth. So this is the overall follow-up. So at present, the child is 9 years old, and this is the picture again sent by the parent in WhatsApp. So I'm sorry for the clarity, but you can appreciate that the child has lost this primary teeth, and the adult teeth have erupted, and they look perfectly fine except for a little bit of plaque accumulation. So we were able to save the teeth as long as it had to stay in the mouth. Now the child is having very healthy permanent dentition. So what are all the anticipated outcomes for lateral luxation? According to Anderson, root resorption can happen in 39% of the cases. Pulp necrosis can happen in 77%. So if pulp necrosis happens, we will have to consider doing endodontic treatment. And again, endodontic treatment is a separate topic by itself. So we will have to choose the appropriate endodontic treatment for that point of time, whether the tooth has a complete root, incomplete root formation. So based on that, we will have to decide what endodontic treatment is needed. And also root canal obliteration can happen in 11% of the cases, and pulp survival can happen in 11%. So in both our cases, all the 4 teeth with lateral luxation have had pulp survival. These are the anticipated outcomes, especially in primary teeth with lateral luxation. So this is a very beautiful retrospective cohort study which is being done, and this study has found out that pulp canal obliteration happens in 43.3% of the cases, root necrosis in 20%, repair-related resorption in 4%, infection-related resorption in 7.3%, ankylosis-related resorption in 1.5%, and premature tooth loss in 25%. So these are all the anticipated outcomes in primary teeth with lateral luxation. So we had adopted for conservative management for both our cases. So what are the risks if we adopt for such modality of treatment? So there is always a chance for inflammation and infection from the traumatized periodontal ligament and also the coronal pulp. And also there are some potential risks on the developing permanent dentition if infection happens in the primary tooth that was repositioned. And also if we do not use the right technique to reposition the primary tooth, we can damage the permanent tooth bud. So we should always weigh the risks versus benefits before we decide for any conservative management, especially in primary teeth. So, what are all the objectives of management? The main objective is to comfort the child and parent in the acute state. Just imagine a 3-year-old child coming to your clinic with bleeding gums and tooth which are like almost out of the socket. The parents are really in a state of shock. So, what we need to do at that time is really comfort the child and the parent, and also consider what are all the options that we have. And we have to provide timely professional care, because in trauma prognosis always depends on the time we provide the care. So we also need to keep in mind that we should avoid inducing dental fear and anxiety in young children, especially like a child, like our second case, a 3-year-old. We might unknowingly induce dental fear to them. That's the reason we need to think about options like sedation and all that. And also we need to minimize the risk of further damage to the permanent teeth. So these are all the objectives that we have to keep in mind. So, what are all the possible reasons for favorable outcome in two of our cases? So, the main thing could have been the time at which the treatment was provided, because the first case reported to us within the 2 hours of incident, and the second case came to us within 5 hours of trauma. So, which means that we didn't miss the golden heart in trauma. We did provided the treatment immediately, and also the procedure was done very technique sensitively, and it was carried out according to the IABP guidelines. And also we did a proper follow-up of the patient by calling them after the next day, or calling them after 2 weeks, after 4 weeks, whenever it was necessary. We were following them up to see that the tooth was vital and no infection was present. So consider reading this article, which is the outcome of luxation injuries to primary teeth, a systematic review. So this is a very good article which has summed up all the outcomes that are present in all luxation injuries, not just the lateral luxation, all the luxation injuries to primary teeth. So always we need to expect the unexpected and we need to be prepared. So these two patients came to the emergency department when we were actually least prepared to handle them. So what had happened that day was a big learning curve for all of us in the department. So I did not have the adequate armamentarium, so we had to run around. We couldn't take a initial radiograph. So later we arranged for a radiograph in the emergency department. So we did not have the flexible splint, so we had to like run around. Luckily, I had an ortho PG who had a flexible ligature wire which I could use. So I was just lucky that I could get all the needed armamentarium that day in an emergency situation. So, but after that day, we had a meeting and we decided in our department to have a trauma kit which contained all the necessary armamentarium. So every department should always have a trauma kit. So if a patient comes with dental trauma, you just pull out the kit and you will have everything. So because of that, you won't lose the golden heart in trauma, which is very, very necessary for the prognosis of the treatment. So we should also follow the correct technique for repositioning and splinting. When you do not know the repositioning technique, if you're doing it for the first time as a postgraduate student, never hesitate to take help. Like that day, I had just called my HOD and he was right there and he taught me how to do the repositioning technique to put the tooth back into the socket. So you will always have your senior PGs or you will have your teachers there. So never hesitate to get help. If you follow the right technique, is only when you can give a successful treatment. So also semi-rigid splinting is very important. Don't use any material that you have to do the splinting. Because the prognosis completely depends on what material we use and how we do it and everything. So we need to allow for the normal physiological tooth movement. Otherwise, we are going to end up with ankylosis of the tooth. So semi-rigid splinting is very, very important. And also we have to give the correct post-operative instructions to the patient. After you do the repositioning and splinting, if the child goes back home and if the mother gives them an apple and if the child bites on the apple, all your treatment is gone. So imagine post-operative instructions are more important than what you actually do. But the very nice thing is the recent IADT guidelines has incorporated the post-operative instructions in the guidelines itself. So even if you forget or if you don't remember, you can always just download the IADT guidelines or have a copy of the IADT guidelines in your clinic. You can just brush up and inform the patient. So that is very, very important. So these four things we should never forget, be it lateral luxation or any trauma to the tooth. So thank you for your valuable time. So smiling for someone is sweet, but making someone smile is the best feeling. And I really felt really good about making both these two children smile. And 6 years down the line, I'm so happy that their teeth were saved that day. We had a lot of learning experience from both of these patients as a department and me personally as a postgraduate student also. So both these cases are very close to my heart. So I was very happy to share them with you. I hope you all learned something from today's lecture. And I'm sure if you see a patient with dental trauma after today, you will be able to manage them a little bit better than how we were doing it till yesterday. Thank you so much to everyone in the Department of Pediatric Dentistry at Srihar. And also a special thanks to Dr. Muthu sir for giving me this opportunity. Thanks to all the listeners. Thank you.
Thank you, Dr. Anusha. And a kind request to the participants, whoever wants to ask any questions, you can ask the speaker, Dr. Anusha. And if you don't have any questions, feedback form link for the lecture has been posted in the chat box. You can fill the form and claim for the certificate of participation. So I have a few questions, but I'll come at the last, Anusha. And it's open for
Okay.
PGs. Anyone wants to ask, you can ask me.
Good afternoon, ma'am. Thank you for the presentation.
Hi. Yes, Akshya, tell me.
Ma'am, I have a doubt in the first case. Was the pulp vitality taken at the first few visits, ma'am?
No, we did not take in the first few visits. We took it only at 3 months.
Okay. So it was the same, ma'am, in 3 months and the following visits?
It actually the two had little less a response initially, but at 2 years the response was correct. So probably it was in the healing phase, but he had response to cold test, so which means the tooth was vital.
Okay, okay,
But
ma'am.
it was a
And
delayed.
also in the same case, sorry, ma'am?
So it was a delayed response initially for the two teeth.
Okay, delayed response.
Yeah. But
Yeah.
at the following, I remember like at 1 year and at 2 years, the everything was normal.
Okay, ma'am. Okay. And also in the same patient, there was a mild notch on the incisor ledge, ma'am. Was any treatment done to that?
No, we did not. We decided not to do anything because it might not stay there. So we decided not to do it.
Okay, okay, ma'am. Thank you, ma'am.
Yeah.
Hello.
Hello.
Hello, Anusha. It's me, Dr. Reshma. Hello.
Yes, ma'am. Yeah, tell me.
It was a nice presentation, Anusha. Well presented. And usually the vitality test will be checked after 2 days, na?
Actually at that time we decided like even if we do it, it might not be very accurate. Like
Yeah.
there can be like
Mm.
hyper responsibility.
Yeah,
So
yeah,
we
yeah, yeah.
decided to do it after 3 months.
Good case presentation and follow up also is been done, and it was a nice presentation. Okay.
Thank you, ma'am.
Okay. Thank you, dear.
Ma'am, thank you for this presentation. I have one doubt, ma'am. Do we need to take into consideration the pulp vitality for primary dentition
Sorry,
also,
I
ma'am?
actually didn't hear you in the beginning. Can you repeat?
Uh, am I audible now, ma'am?
Yeah, tell me.
Ma'am, do we have to take into consideration the pulp vitality for primary dentition also, ma'am?
So actually, pulp vitality in primary dentition is very challenging, especially for a 3-year-old. It's very difficult whether they are they have to respond to us like whether they are having
Yes, ma'am.
yeah. So
Exactly.
I couldn't really do pulp vitality testing for that boy. But however, we did a proper clinical and radiographic follow up, and he never developed any infection or anything. and the root apical fragment had resolved, and everything was looking fine radiographically and clinically. And now that he's lost the tooth and he's got his permanent dentition also, so I think pulp vitality in primary, as we all know, it is a bit challenging to do. If there
Yes.
was discoloration of the tooth or anything, then we would consider doing a pulpectomy, but there was no discoloration. So
Okay, okay, ma'am. Thank you, ma'am.
Other questions from postgraduates or any participants? Okay, fine. Respected Dr. Steven sir and Dr. Roshan sir and Dr. Deepesh sir, welcome to the program. Almost thanks for joining, sir. And if you have any questions from your side, you can ask, and you can tell about how was the presentation, sir. Anusha, am I audible, right?
yeah, yes, Vignesh, you're audible.
Actually, they could not hear Nanik.
Vignesh, I just joined. By the
Yes,
time the
sir.
presentation
Sorry, sir.
got over, I
Yes,
was
sir.
in
Yes, sir.
the middle of the work. Okay,
Yeah,
so
fine, sir. Yes, sir.
maybe I'll see the video
Yes,
recording
sir.
and then
Yes, sir.
maybe.
Yes, sir. Sure, sir. Sure. Yes, sir. So thanks, Anisha. Thanks for the detailed presentation. I have a few doubts. So if 7.3 has been lateral luxated, so any tips for the isolation or any other alternative for except the wire sprinting, that semi-rigid sprinting?
Sorry, what? Like 7.3?
Ah,
You mean specifically the tooth 7.3?
yeah, 7.2 and 7.3, for example.
Or for the lower, you mean?
Lower canine.
Uh, so for isolation, usually we can always use like cotton roll isolation, which is quite good. If you're doing under sedation or anything, it becomes even more easier to do proper isolation. So under physical restraints, isolation is very difficult. So we can even use the isolate system and all that if you're doing under isolation. But if you're doing under physical restraints, only cotton roll is going to be helpful.
Uh, and any tips for the repositioning or replacement of tooth back to the socket?
So that technique, it is very technique sensitive. So we need to follow that digit repositioning
Digital.
pattern. Like we have to press it downward and then upward. Otherwise, we are going to disengage the bone as well as the tooth. And also, there will be blood clot if you are going to do the procedure after. Sometimes we do it after a day or two in clinical practice. So at that time, that could be like blood clot within the socket. So we need to do it in a very right way so that the blood clot gets dislodged. Otherwise, the tooth is not going to go back into the socket. So I think the recent guidelines have very clearly mentioned the repositioning technique and all that, which is very helpful. At that point, 6 years ago, I think we had to read more about it to find out. But the guidelines now is the wordings are much better now.
Yeah, sure. But always, sir says, what sir says, after any trauma case comes to department, you have to read the ambition. Still the same
Yeah,
habit goes on. And whatever case, anything, a simple, uncomplicated torn fracture or any complicated, any type of trauma, if it comes to department, we follow the same rule. At least you have to read the baby Anderson and then they have to take up the case.
correct, correct.
So
So the
that's
key
what,
is Anderson and the IADT guidelines.
yeah, recent
These
guidelines.
are the recent guidelines. These two, you have to be like very thorough. Even if you forget a few things, having a copy of it, like always sir says, if you
Yes,
forget something, we can always go back to the copy, read it, and then see the patient. So it's very, very important that we have the guidelines handy.
yeah, sure. And thanks for clarifying the doubts. And now it's time to share the certificate once again.
Thank you very much.
Yes.
Nusha,
Yes, sir.
uh, excellent presentation.
Thank
Thank
you.
you. Yeah, and I want to say hi to everybody at the Pedo Department at Ramchandra. It was a
Hello, sir.
privilege to be part of the learning process.
Nice
Thank you.
having you, sir. Thank you so much.
Thank you so much. Yeah.
Yes, sir. Thank you, sir. Thanks for your kind words, sir. So, on behalf of Department of Pediatric and Preventive Dentistry, so we just shared the screen of the e-certificate of a guest lecture on lateral luxation injuries in young patients with a 6 years follow-up in primary and permanent teeth. So, as we discussed, Anusha, I will give the hard copy of the certificate
Sure.
to you in person. Fine. So, this is the e-certificate.
Thank
And
you.
I'll also send the recording by today night, the lecture recordings and also the feedback form which participants have submitted. And then I'll mail to you by tonight.
Sure. Thank you, Vignesh.
Sure. Thank you. Thanks for joining. And thanks for the. If any doubts of any reading materials, if the participants ask, I'll just get you back and then I'll coordinate.
Yeah, actually, I have all the articles and the guidelines you can always download, but
Yeah.
the other articles that I have put in my
We need
references.
to do lateral luxations if needed. If anyone asks, I'll just coordinate with you and then I'll get
Sure,
back.
definitely, I can send it to.
Sure. Thank you. Thank you so
Thank
much.
you.
Thank you for all joining, participants for all joining the program. Okay. Have a good day. Thank you.